Hello, this is Dr. Seth Gerald, and today I'm going to give you a presentation on obesity is a disease and it can be treated. Our outline is what is obesity and overweight, what are the causes of it, we'll look at the epidemiology, we'll look at some conditions that result from obesity and overweight, we'll look at some of the hormonal and inflammatory changes, also life expectancy changes. We'll then transition over to treatment and then examples of some patient outcomes. So, what is obesity and overweight? Well, we all know the typical body mass index definition, where it's weight in kilograms divided by our height in meters squared. This gives us a value of an estimate of how much excess energy storage or body fat a person may have. So in that example, overweight would be a BMI from 25 to 29.9. Obesity is 30 to 35, and then severe obesity is 40 and above. But I like the Obesity Medicine Association's definition better here at the bottom of the slide. So it's chronic, it's relapsing, so it happens over and over. There are multiple things that contribute to it. It's a neurobehavioral disease, meaning it has more to do with our brains than we realize. And it all leads to body fat promotes adipose tissue dysfunction. So what happens is as you get adipose tissue building up, the tissue dysfunction is causing some metabolic, biomechanical, and psychosocial health consequences. Now, body mass index is not the best way to check a person's body fat. One of the best ways is by DEXA scanning or by MRI scanning the entire body. As you can see in this picture, you can see the excess body fat. So for instance, if a bodybuilder comes in, their BMI may be much higher. But in fact, if we look at a scan of their body, then it's not as high. Now we're looking at getting a bioimpedance scanner that does this same thing and measures how much water content, how much muscle content, and how much fat content a person has, so it's much more accurate. Have you ever seen this before, where people tell you it's just simply energy in and energy out? So if you take in more energy than you burn, then you'll gain weight, or eat less and move more. If you think this is the correct full picture of what causes obesity, it is not the full story. There is much more to this than just eat less and move more. We're going to look at some of the complex causes. So this first slide is a slide that lets us know some of the inputs and outputs that can lead to hunger and can lead to obesity. So if you look on the left side, one person may have a different resting metabolic rate than another. Also, as fat mass increases, leptin and other adipokines change. So leptin increases, other adipokines, which are these inflammation markers that come from our adipose tissue, change. And this can inhibit our hunger or increase or decrease our hunger. Then we go over to the right side, and there are many appetite-stimulating hormones. One of them is ghrelin. It's produced in the stomach. The way I remember what it does is the stomach growls like grrr, and so ghrelin increases our hunger. There's other hormones in the GI tract that do this as well or inhibit our hunger, such as CCK, PYY, and GLP-1 all inhibit our hunger, and they all go back to the brain to hit a certain area to decrease or increase hunger. Our next slide looks at a lot of different contributing factors to obesity. So let's start at the very bottom, gut microbiota. So let's say that the bacteria that are in your gut are different than another person's. We know that people who are smaller in size usually have a different type of gut bacteria or percentage of those gut bacteria than other people who may have a larger size. Other things that can lead to energy storage would be things such as if your mother had gestational diabetes, or if your mother was a heavy weight when she had you. Other things that can lead to excess energy storage. So we're going to move over to the right side now. So looking at the bottom, prenatal air exposure, prenatal air pollution exposure, increased stress, sleep deficits, which we'll talk more about later. Lots of different contributing factors why one person's has a much harder time losing weight or a much easier time gaining weight than another. So it's not just move more and eat less. So weight cycling or yo-yo dieting. You'll see this done a lot. And why this is so dangerous is a person gains weight, they diet, their metabolism slows down. They end the diet. Well, guess what? They go back to normal eating and they gain the weight back. There was a trial done, the Biggest Loser study. So the Biggest Loser, which was on television, there were 14 contestants. So they measured their basal metabolic rate at the beginning of this trial. They lost a lot of weight. They measured it at the end of that. And then 6 years later, 13 of the 14 contestants had gained their weight back. And they looked at their basal metabolic rate, and none of their basal metabolic rates came back to their normal level. So every time we lose weight, our basal metabolic rate drops and it never goes back to a normal value. This is why it's so important that we not yo-yo diet, but that we do types of nutritional interventions that we can do the rest of our lives. So let's look at the epidemiology. I want you to think about this question. What do you think the prevalence or percentage of obesity is in adults in the United States? Think about that a minute. Think of a number. Is it 10%? Is it 20%? 30%? 100%? What do you think? 39.8%. So almost 4 in 10 Americans have the disease of obesity. What do you think about the percentage of overweight and obesity together? So we take everybody with overweight and everybody with obesity. Think about that in a minute. So we know it's more than 40% because obesity was at 40%. What do you think? 70.7%. So 7 out of 10 Americans have either overweight or obesity. Which states have the highest rates? What do you think? Think about some states in your head. Okay, and where is Alabama ranked? I think we're number 1, 2, 3, 4, 50. What do you think? Well, let's look at it. First, we're going to look at the states with the highest prevalences. So you can see the southern states, Alabama, Mississippi, Arkansas, Louisiana, Oklahoma, but also West Virginia, and then Iowa. Okay, now let's look at where we're ranked. So number 1 was West Virginia, and number 50 was Colorado. Alabama's ranked number 4. So we're not only good at football, we're also good at bad eating habits and the rates of obesity. So what are some of the chronic conditions that result from obesity and overweight? Well, these are just a few, but there's over 200 obesity-associated disorders. There's type 2 diabetes that directly results from having central adiposity, high blood pressure, high cholesterol, cardiovascular diseases such as heart attacks, and even congestive heart failure, strokes. There's many cancers that result directly from obesity, fatty liver disease, which is becoming more and more prevalent, sleep apnea, and arthritis. This is a slide that shows how obesity causes high blood pressure. So what happens is we develop central obesity around the stomach, and that leads to insulin resistance. Leptin levels increase, our sympathetic nervous system increases, our renin-angiotensin system increases, aldosterone production increases, and we get more salt sensitive. So what happens is we retain more salt, our arterial pressures go up, our sympathetic nervous system is increased, we get constriction of our blood vessels, and this leads to damage of the kidneys, and it's a catch-22. Just continues and continues. So some chronic conditions that result from obesity and overweight. For every 1 kilogram of excess weight, the risk of diabetes is increased by 9%. 80 to 90% of those with type 2 diabetes have obesity. Those who have a BMI of 35 or higher have 6 times the risk of type 2 diabetes. Do some more. Each BMI, body mass index increase of 1, increases the risk of heart failure development by 5% in men and 7% in women. AFib by 4%, hemorrhagic stroke by 6%, and ischemic stroke by 4%. Non-alcoholic fatty liver disease is in 15 to 30% of the general population. It's up to 74% of those with obesity and 90% of those with a BMI over 40. Sleep apnea, 30% of people with obesity have sleep apnea. And with a BMI over 40, it's 50 to 98% of people, depending on what study you look at. Gallbladder disease. Obesity doubles the risk of gallstones by 1% per year. Cancer. For each BMI increase of 5, there is a linear increase in the risk of cancer of the uterus, gallbladder, kidney, cervix, thyroid, and leukemia. And obesity is directly associated with cancers of the liver, colon, ovarian, and postmenopausal breast cancers. And depression. In those with obesity, major depressive disorder is increased by 1.5 to 2-fold. So many reasons why we should treat the disease of obesity. So what kind of hormonal changes and inflammatory changes do we see with obesity? Well, we get a lot of visceral adipose and inflammation. So all our organs develop adipose tissue and therefore inflammation. Fat's one of the biggest endocrine organs in our body, and it secretes these inflammatory cells known as adipokines or inflammatory proteins and free fatty acid. This increases inflammation, leading to insulin resistance in the muscle, increased triglycerides, and many associated pathologies such as atherosclerosis, liver disease, and many other downstream effects. This is looking at some life expectancy changes. So if you'll notice, white men are on top and white women on the bottom. On the x-axis is body mass index, and on the y-axis is years of life lost. So as you can see, as body mass index goes up from 25-ish to greater than 45, the years of life lost can go up to 12 just from that. Now, if you'll notice, at a younger age, if we develop it at a younger age, the impact is much, much worse. So if we can treat this at a younger age, it's much better. If someone has a BMI of 30 to 35, there's a decreased survival of about 2 to 4 years. Now, if it's 40 to 45, it's 8 to 10 years, or similar to that of a smoker. If someone smokes and has obesity, then it's 13 to 14 years. One thing I want you to know is that Vogue magazine has it wrong. Some of these other magazines have it wrong, what you hear in the media. There's no such thing as being healthy and having obesity. There's no such thing. There are so many downstream effects. But it's okay because we can treat it. So treatment. So I follow the 4 pillars of weight loss as guided by the Obesity Medicine Association. So number 1 is nutrition. Number 2 is physical activity. Number 3 is behavioral changes. And number 4 is medication. So let's start with nutrition. What do you think is the best nutritional intervention, or if you have to call it this, a diet, for weight loss? So think about that a minute. Is it Mediterranean diet? Is it South Beach diet? Is it Weight Watchers? Is it low carb? Is it calorie counting? What is it? Well, there's been plenty of studies to look at this, and with almost any diet, you can lose weight. But our key is to use one that is evidence-based and one that the patient can adhere to for a lifetime. So every patient is individualized. We need to find something they can do for the rest of their lives. So what do I use? I use a combination of all of these, sometimes one, sometimes multiple different types of nutritional plans. Mediterranean, limited carbs less than 70 net, or keto diet less than 20 net. Calorie restriction, portion control, intermittent fasting. We use the DASH diet for blood pressure alone. Meal replacements, meal prep, and hybrids. But our main goal is to teach patients how to eat more healthily. You can do these dirty and lose a little weight, but we're trying to improve your overall health as well. The second pillar to weight loss is physical activity. So it is recommended in every single person 150 to 300 minutes per week of moderate intensity cardiovascular exercise. If you do vigorous exercise, all that's needed is 75 to 150. And then it's also recommended to do muscle strengthening 2 days a week. So we want to build up those muscles so that they will burn more calories during the day. To prevent weight gain, that is still the recommended amount, but to prevent weight regain, let's say you lose the weight and now you don't want to gain it back. The information actually says we should be doing more like 200 to 420 minutes a week to help prevent weight regain. We also encourage NEAT, N-E-A-T, non-exercise activity time. So increase this as much as possible. These are things like parking at the back of the parking lot. So things that we can increase our activity without actually having to set aside time to exercise. Using the stairs instead of the elevator. Taking the long way to the bathroom. Making an alarm on your watch to move or to stand. Getting a certain amount of steps a day. We focus on those significantly. Now, looking at physical activity, there was a trial done in 1988, and it had two sets of people. The ones in the purplish color were those who were sedentary, and the ones in the yellow color were those that exercised. Both of those were put on a very low calorie diet, and at the x-axis we see how many weeks they've been on this very low calorie diet. The y-axis tells us their metabolic rate. So both groups, their metabolic weight dropped as they went on the low calorie diet, which we expect. But the group that was sedentary, it stabilized off at about 1400. But about half of those who did the exercise, their metabolic rate continued to drop. So for some people, not all people, but some people, physical activity may lead to them not losing weight as much. We're not sure why it's in some people but not others, but it's important to listen to patients in this perspective because even though there are many health benefits from physical activity, and I always recommend it, it may be true no matter how much you increase your activity, that alone will not lead to weight loss. So the third pillar is behavioral. All four of these things can lead to increased weight. Eating disorders, body image disorders, sleep disorders, and mood disorders such as depression, anxiety, and so forth. So when a patient comes to me for their first visit, we do screening questionnaires of all of these. So this trial here was looking at patients who got 8 hours of sleep versus 5 hours of sleep. In the patients who got 5 hours of sleep, their body mass index increased by 3.6%. What was even more impressive is leptin, which is a hormone made by fat tissues that makes you feel full. So it decreased by over 15%. So it's supposed to make you full, but it decreased. And then ghrelin, that hormone that's made in the stomach that makes you feel hungry, it increased by 15%. So extremely important to get 8 hours of sleep every single night. So some things that we do for patients who are having troubles with these. So we use the CBT iCoach app. It's actually through the Veterans Administration, the VA. It's free and you can get it, and it really can help you get better sleep using some cognitive behavioral therapy. And it's free. So if a patient has depression and anxiety, they may need treatment with certain medications. They may need to do some cognitive behavioral therapy with something like WISA, which we use quite a bit, or they may need a referral to psychology or psychiatry or a counselor. We also encourage patients to weigh daily. There's been plenty of trials to show that keeping a food diary or log is extremely important in keeping weight off. It helps keep you accountable. I really like cognitive behavioral therapy for weight loss. There's a really good book that I like called The Diet Trap by Judith Beck. We use it a lot. It's a lot of interventions. You can retrain your brain how you should think about food and how to respond to it. Teach patients to savor their food. Every bite you eat, you want to savor. And start eating at the table. Extremely important to do this so that we don't associate other rewards with food. So the last pillar of our treatment is medications. So we use a lot of medications to assist with weight loss. Now, once a patient gets started on medications, it may be something they need to take for the rest of their life. But every once in a while, patients do not. It's just like diabetes. Once you start on a medication, you probably need it. Or blood pressure, you probably need those for the rest of your life. But if we can get on one medication to control obesity, and after getting on that, we lose weight and are able to come off our cholesterol medications, our arthritis medications, our diabetes medications, our blood pressure medications, and so forth, then it is a win-win. These are some of the medications we use on the left, but Belviq was taken off the market in February of 2020 due to concerns of an increased cancer risk, so it's no longer used anymore. And some of these medications are used off-label, not approved for obesity by the FDA, but do cause weight loss, and we use them in select cases. How do they work? How do medications work to promote weight loss? Well, it's all in the part of the brain called the hypothalamus, and there's different portions of the hypothalamus. But we break it into two different pathways. If you'll notice on the left, there's one called the orexigenic pathway, meaning a hunger pathway, and on right beside it is the anorexigenic pathway, or the pathway that leads to somebody feeling full. So we have medications that can block the orexigenic pathway or stimulate the anorexigenic pathway or downstream effects of those. There is no increasing the metabolic rate with any types of diet medications. How much weight can we expect to lose? Well, this is a trial of some of the newer anti-obesity medicines. Lorcaserin on the left was taken off the market in February 2020, so we will ignore it. But for the others, these are in kilograms. So we can expect about 9 kilograms with phentermine topiramate. Contrave in the green, we can expect somewhere around 5.2 kilograms. And then liraglutide, which is Saxenda, we can expect about 6. So if you multiply all of those by 2.3, that gives you about how many pounds on average. Now that's an average, and it's not looking at how much each person will lose, because some lose a lot more, some lose less, and we have to tailor it to each patient. Do they work long term though? So if we look at the Saxenda trial, you'll notice the gray area is the area when the medication was started. And the blue line is liraglutide, and the gray line is placebo. So it was started at week 0. Patients lost a lot of weight. They stabilized off at about week 29-ish, and then they kept them on the medication to keep the weight off, which did very well. It plateaued. But then at week 56, they took the medication off, and they began to gain the weight back. So we know it works long term. It's just if we stop it, weight does begin to creep back up. Do the medications alter our health outcomes, though? Well, if you look at those medications, you'll notice that their cholesterol, LDL, decreased, their triglycerides decreased, their good cholesterol, or HDL, increased, their A1C, which is a 3-month average of their sugar, decreased, and their systolic blood pressure decreased in all but the naltrexone bupropion combination. So there are many medications that can promote weight gain. Antidepressants, and you'll see them listed there: Celexa, Lexapro, Cymbalta, Elavil, mirtazapine. There are some antidepressants we can change to that do not cause weight gain. Antipsychotics, and you'll see them listed there. There are miscellaneous medications that can cause weight gain. Antihistamines, such as Benadryl, can. Steroids, beta blockers, especially the selective beta blockers like metoprolol and atenolol, and estrogens can cause weight gain. Diabetes medicines, not all, some cause weight loss, but these, such as pioglitazone, insulin, and sulfonylureas, all can cause weight gain. Neuropathic agents, so things like as gabapentin or Neurontin or Lyrica or pregabalin cause weight gain. And then probably the most common that I see are sleep agents, so things such as Ambien or Lunesta, and even to some portion trazodone. These can be extremely difficult to get off, so I do not like using these at all for insomnia. In fact, they're not approved for long-term use of insomnia. At least Ambien and Lunesta are not. But it can be extremely difficult to wean these off and do something different. So these are some outcomes of patients that have had our weight loss program here. and have lost quite a bit of weight. The before and after pictures. These are some resources that I really enjoy using. The Obesity Medicine Association has a lot of resources. You can visit their website at obesitymedicine.org. My website here at the internalmedicineclinic.com/weight loss has a lot of resources, some more videos by me. These are some of my favorite trials: the direct trial, the OptiFast trial, the intermittent fasting trial, look ahead trial, and the Biggest Loser trial Biggest Loser study we looked at earlier. And if you have any questions, please just let us know. Thank you for listening to our presentation.